Alright guys, I have another video for you tonight. Let's just get into it. We have a 24-year-old female. She comes to the office because of 2 months history of abdominal pain and diarrhea. She has been having 3 to 4 stools daily, occasionally with small amounts of blood. She's had some weight loss. She denies any recent travel or antibiotic use. She's afebrile, pulse is 88. Abdominal examination shows tenderness in the right lower quadrant, pain without gardening or rebound. No perianal lesions are seen. Labs show hemoglobin of 10. ESR is elevated. Stool cultures are negative. Colonoscopy shows inflammation limited to the terminal ileum, with areas of ulceration separated by normal mucosa. The colon and rectum appear normal. Biopsy shows transmural inflammation. What is the most appropriate initial pharmacotherapy? So this is what is the next best step. What do we think the diagnosis is? I think it's looking like IBD, to be honest. It's going to be IBD. We're thinking Crohn's disease, ulcerative colitis. This is actually Crohn's disease. And the reason why is because we see inflammation in the terminal ileum. And I'm going to go through this question. This question I want to really dig into this question and give you some test-taking strategies that's more important than actually just getting the diagnosis, because I think a lot of you read this question and you're able to tell that this is Crohn's disease. It's really not that tricky. But what I want to dive into more is test-taking strategies. So first of all, let's look at the question stem and assess the severity of the disease. Is this patient presenting on a scale of 1 to 10? How severe is the presentation? For her, honestly, I would say she is kind of in the middle. It's definitely not severe, where it's complications of Crohn's disease. Maybe she's unstable, she's tachycardic, maybe she's deteriorating, she's afebrile, she doesn't have any signs of sepsis. So definitely not a 10. But it's also not a 1. She's had 2 months of abdominal pain, she's had some weight loss, she reports 3 to 4 daily stools, small amounts of blood. All of this terminology, small amounts of blood. They're not saying they don't mention any severe diarrhea. Really, I would say this is maybe a presentation of a 4 or 5, okay? Maybe even a 3. So in the middle. It's not, a presentation of nothing, and it's not a severe presentation. And so let's quickly go through these answer choices. We have mesalamine. This is wrong. Mesalamine is more typically used in ulcerative colitis. So this is used in UC. Oral steroids versus IV steroids. Which one are we going to choose? We'll get back to this. We'll keep the option open. Infliximab. No, this is not the answer choice, and I don't even want to dig into why it's not the answer choice from a medical perspective, but just from a test-taking strategy. Infliximab, this is a biologic. This would be treating a severe presentation of Crohn's disease. Let me put it that way. And this patient is not presenting with a severe case. Maybe if she was presenting with an 8, 9, or 10, then we would use infliximab. Total colectomy, this is absolutely the wrong answer choice. This patient is not presenting severe enough for both of these answer choices. We can just eliminate it based off just looking at the presentation and correlating the severity of the presentation with how aggressive we're going to treat it. These two are very aggressive. They would only make sense in a patient with a severe case. Oral mesalamine, that's wrong because we're using it in UC. Now we have between oral and IV. And the answer here is going to be oral steroids. And the reason is oral steroids is used in mild to moderate cases. This more correlates with the 3, 4, 5 range. IV is going to be a little bit higher. If it was a presentation of an 8, 9, 10, IV is going to really be saved for those severe cases. So let me talk a little bit about Crohn's disease and what you should know for NBME. There are 3 main things I want you to keep in mind. Number 1, the presentation is always going to be chronic or recurrent. Here we see 2 months history right here. NBME is going to mention, patient comes in a year long, 3 or 4 months long, and this really differentiates it from acute GI, gastroenteritis. The second thing they're going to mention is complications. Rarely will they ever give you Crohn's disease and just mention the diarrhea. They're always going to mention something in regards to the complications. So most commonly, when it comes to complications, they're going to mention sinus tracts. They're going to mention an abscess or especially perianal abscess or perianal fistula. That's the word. So perianal fistula. They love perianal, guys. Perianal fistula, perianal abscess. Anytime patients are having perianal symptoms, you combine that with chronic or recurrent diarrhea. This is, kind of almost always is going to be Crohn's disease. And then the third thing that NBME loves to ask and mention when it comes to Crohn's disease is right lower quadrant, mass, tenderness, ileocecal tenderness. They love the region. IBD typically involves the ileum, the terminal ileum, and so they're going to mention that in some way. We saw that here in the vignette, tenderness in the right lower quadrant. Here they didn't mention the perianal lesions, but you combine the chronic diarrhea, right lower quadrant pain, weight loss, and then of course a colonoscopy. This one was a pretty easy question as far as identifying Crohn's disease. So yeah, these are the main three things I want you to look for in Crohn's disease. All right, let's get into the next question. A 31-year-old man comes to the physician because of 4 months of intermittent abdominal pain and loose stools, 3 to 5 bowel movements daily without gross blood. He has had some weight loss. 2 weeks ago, he was treated with antibiotics for painful swelling near the anus that required an IND. He does not smoke cigarettes. He drinks alcohol socially. He returned from a camping trip in Colorado 6 months ago, but did not seek medical care at the time. He does have temperature. He's febrile. Examination shows mild tenderness in the right lower quadrant without rebound. He has a small healing perianal incision site is noted. In the lab studies, hemoglobin is 11.2, MCV is 88, leukocytes, he has some leukocytosis, ESR elevated, stool cultures, ova, parasites, and C. diff are negative. And then CT scan shows segmental thickening of the terminal ileum with adjacent fat stranging, which is the following is the most likely diagnosis. Well, obviously the answer is Crohn's disease, given that this is a Crohn's disease video. But let's get into the other questions. And I really want you, like I said, I want to teach you guys test taking strategies. My channel is really focused on scoring high, and sometimes you just have to rely on these test taking strategies so that you can get through the questions quicker, which makes most sense, and really score in those high ranges. So Crohn's disease, why? We have chronic symptoms, 4 months. We have weight loss. This is a key feature. They almost always mention weight loss. And then we have a perianal symptoms. So swelling near the anus. What is this? What are they talking about? This is an abscess that required. This is an IND. So they mentioned, anal, perianal symptoms, chronic diarrhea, abdominal pain. That's should give you away disease for Crohn's right away. Let's go into the other diseases. Celiac disease, no, that would be wrong. What is it wrong? It does cause chronic diarrhea. It does cause weight loss. It does cause iron deficiency and anemia, bloating, but it does not cause the anus symptoms, anal symptoms. It does not cause perianal abscess, and it does not cause focal terminal ileum thickening. So here thickening. So that's just going to be wrong. When would celiac be correct? If it was chronic diarrhea plus iron deficiency anemia, and then you're going to see maybe perhaps some rashes, dermatitis herpetiformis specifically, positive TTG, IgA, and the imaging is going to be normal mainly. Let's look at infectious ileitis. This is absolutely wrong. This is a distractor. This guy has been having these symptoms for 4 months. This is not an acute presentation. He does have a fever. He does have right lower quadrant pain. It can mimic appendicitis, for example, Yersinia. But it's usually self-limited. Symptoms are not 4 months long. Has nothing to do with the perianal abscess. And guys, this can really rule out a lot of other diseases. And then quickly, let's just go through IBS. This is absolutely wrong. This does have chronic abdominal pain, so check. We can't have chronic symptoms with IBS. We can't have diarrhea. We can't have constipation. But IBS will never cause weight loss. Okay, IBS cannot cause weight loss. You will not have anemia with IBS. You will not have elevated ESR. Another protein, I want to type it out here. It's called fecal calprotectin. This test can be used to differentiate between IBS and IBD. This is going to be positive in IBD, negative in IBS, and this is basically a marker of inflammation, of intestinal inflammation. So this is another test. If you ever see fecal calprotectin positive, that means it's going to be Crohn's disease right here. So IBS is not going to cause all of these, constitutional symptoms of weight loss, fever, ESR elevated. It's just simply more of a functional disorder, and labs and imaging are going to be normal. And then lastly, ulcerative colitis. This is the closest we are to Crohn's disease. What rules this out? Ulcerative colitis usually causes bloody diarrhea, and it's continuous inflammation from the rectum proximally. It's not going to affect the terminal ileum. So this imaging right here is going to rule out ulcerative colitis. And the other thing is, ulcerative colitis usually doesn't affect the perianal region. It starts from the rectum. Okay, so it's not going to cause abscesses. It's not going to cause fistulas. It's not going to cause strictures. It's going to be limited to the rectum and go proximally from that. And usually the treatment for ulcerative colitis, you can actually treat it with a colectomy. And that's it.